The past year has been a year of disruption, and every healthcare facility has felt the impact. Financial pressure created by COVID-19 and compounded by a critical staff shortage means that we need to do more with less. As an industry, we must rely on predictive and prescriptive analytics tools and cutting-edge lean principles to transform capacity management. Better healthcare is possible through better math. Over the next 2 days, you'll hear from leaders in healthcare and experts in AI, participate in breakout sessions by field of expertise, and learn how your peers are using analytics and AI tools to optimize their core operational processes. Leave with a new understanding of how you can harness the power of data to improve utilization, increase patient access, and unlock capacity. Start working towards your future. Take the first step to transform.
And in order to do that, what we do need to do is to optimize capacity through what we think of as air traffic control, building these pillars of excellence where we are able to extract all the juice we can from our ORs, from beds, from emergency departments, as well as all of the outpatient units we talked about. Done right, this can be highly valuable to every health system. It increases patient access, increases patient satisfaction. It also is wonderful for the bottom line of every health system. So just to give you a canonical example, if you think about an average 10 hospital health system with 10 or so ORs, 300 or so beds, 20 or so infusion chairs, if you add up the value that can be created by unlocking this kind of capacity, the numbers are pretty large. It's almost $100 million in increased revenue through increasing access. So this is the best win-win that we can create for patients, for staff, for health systems economics, and for every future generation.
Types of things, but to just sit back and say, well, this is the way it's been, this is the way it's always going to be, we have to flip that dynamic. We have to flip that dynamic in healthcare in general, but we really try and talk about that a lot at community to say, that's not acceptable anymore. The speed of innovation, the clock speed in healthcare, the speed of other entrants coming into healthcare is only accelerating. It's not going to slow down. So we have to change our thinking as well. And I think it comes with those two things: empowering people, continuous improvement, servant leadership, curiosity, and empowering people to solve problems.
As a manager of an OR, you want to be able to look at your staff room utilization. That is the rooms that you have staffed and have available block for surgeons to post into. So you want that number to grow and get higher and higher. As our utilization has climbed to record levels since COVID reopening, we were going into the 60s and 70% utilization, and then now we're pretty much consistent in the 70s and upper 70s in some of our locations, which is, of course, our highest months on record. This really tells a story of how your ORs are being utilized, because when you're looking at just solely block utilization, those numbers can be manipulated or adjusted based on rules. These here are more cleaner. The room utilization report, staff room utilization report, is a lot more effective. And you can see we've had a 13% increase in utilization of our surgery centers over the past year or so. A great example, I think we've touched on it a little bit before, one of our hospitals, Alamance Regional, the trust and the exchange to find OR time is tremendous. That center, that hospital has shown a dramatic growth in the use of IQ and the use of open table to find these cases and put them on. And their staff utilization actually has grown into the 80 percentiles since the pandemic started, and now that we're fully open, seeing levels unheard of in that center there. So they've done a really good job there.
And then finally, we are looking at what will happen tomorrow. You can see here, this predicted bed balance is on that capacity Huddle tool. Everyone at our organization all leaders have access to this tool, and we can see where we are going to end up the next morning if we don't operationalize further surge plans, etc. So our emergency department often uses this. If they go, all right, we're going to be -3 beds versus -20 beds, they're able to convert that into ED boarders, and they know that they need to ultimately request inpatient nurses because they will be boarding in the morning. So we leverage this predicted balance to pull the trigger on our surge plans sooner so that we can create capacity and don't end up behind the 8 ball the next day.
Here at Vanderbilt Ingram Cancer Center, we've seen a 30% decrease in our chair wait time and a 27% decrease in our drug wait time. So, that's looking at the time the patient actually checks in until we room them, and then the time that the patient checks in until we administer that first drug. We've also seen an 8% increase in our volumes using the same number of chairs. So I think what's important to point out about this and what makes it particularly impressive is we've opened several other locations during that time and, added infusion resources there. So that's been a siphon away from our main infusion center where we're talking about these numbers, but we've still seen that 8% increase in volume. So, it's very impressive the amount of growth we've had and the amount of volume we've been able to add at this one infusion center thanks to having the IQ system in place.
Based on the 20 quantitative questions that we ask. And of the 20 interviews, the conversations that we had, the class score for LeanTaaS was 96.5, which is genuinely a fantastic performance score. Every year we give out best in class awards. Many of you may have seen the best in class publication. If you haven't, please come to the class website and you can take a look at our ratings across 150 or so segments. Most software segment award winners are between 87 and 91. That's kind of the range of winners in our scale. And LeanTaaS with 20 conversations, a 96.5 is really a great score. I usually only see this when we do like a 4 or 5 because it's a really small list. So hats off to the LeanTaaS team. Their performance, functionality, and technology really stood out from these conversations that we had.
And this then really takes flow to a new level of proactive problem solving, which is kind of the core and of our product, of how it works and how it really turbocharges existing processes and where you are at in your current state. Accuracy was above 90% over a long course of time. Despite all those changes in the kind of dynamic nature of real time, our models still with great accuracy reflect what discharges are going to look like. And that allows for a more realistic actual workflow or prioritized work list that makes it that much more satisfying, and you can actually get patients out the door in a safe and efficient manner.
We went live with IQ in May of 2019 at our busiest infusion center. Our Lake St. Louis office sees an average of 30 to 50 patients a day, and at that time we were seeing about 40 patients a day. We have 17 infusion chairs, and at the time we were also undergoing an expansion to the room where we were looking to add 2 more infusion chairs and possibly an additional infusion nurse. With the implementation of IQ, we were able to increase our volumes by 18%, decrease our wait times for access to a chair by 44%, and at the scheduled appointment time, and lower the wait time for drugs from the pharmacy by 25% due to decreasing the AM bottleneck we were experiencing.
business case standpoint, you're going to see more and more companies and more healthcare systems starting to show the benefit. And I think many of us who've attended this conference understand it better now than we did a couple of days ago. But certainly, when we go to COOs, CFOs, or if we go to budget committees, if we go for capital, or if we go to buy software, some of these savings that are being identified by early adopters are pretty compelling. And as we're trying to find places that would reduce costs without reducing staff, because staff is precious to us, that's our nurses that are hugging our patients. Some of these third-party software packages, some of these systems that we used to shutter and back away from because you'd rather buy a nurse than a computer program, this computer program might actually buy or provide the resources to have a dozen nurses. And so the ROI is pretty compelling.
The people piece, starting with, you've got to have senior leadership on board, supporting, helping drive the change. Just talking with the surgeons, talking with the anesthesiologists, making that happen. And then that lends to a culture of acceptance and a culture of being willing to try new things, try new technologies, even though things have been done the same way for years and years. On the process side, you've got to have your guidelines, you've got to have things documented about how blocks are given, how blocks are used, how time is released, and then also how it could be shifted from one surgeon to another if needed. So having all those things outlined, having the framework to do that is really important, and just creating, a system-wide approach to the consistency of how we do these things. And lastly, having these processes not only help day to day as we do our work, but when you come to a time of crisis like COVID, or who knows else what might possibly hit, in Florida we have hurricanes, who knows else what could come, but having these systems and processes in place makes it so much better, so you can pivot and be agile very quickly. And then lastly, around technology, you want to make sure that you bring your key stakeholders along, and that you're choosing partners who can help you, just like IQ has done with us, to solve complex issues that may not have been part of their canned deliverables, but those that can work with you and just really take your processes to the next level.
Now, the way we've done it, and we've done this with LeanTaaS, as you probably remember, we usually start out with what I call phase one, not a pilot project, but a phase one, which is we try this out in a smaller hospital and run parallel process with our old systems, just so we can see, is this working well? And what is the feedback from our staff, from our nurses, from our clinicians, from anybody that touches this product? And we usually try to run that parallel process for 3 months. But I can tell you, 90% of the time, when we run this parallel process, people have come back to us, and within 2-3 weeks, they say, we're going to ditch the old way because this is so much better, right, which is really rewarding for us.
Since September of 2021 to April of 2022, we have seen daily completed volume up 14%, meaning we went from completing about 92 infusion patients a day in September of 2021 to over 105, and I think recently close to 108 in April, May of 2022. And that was supported by the fact that we were able to limit the number of shrinkage, same-day shrinkage and no-shows from over 20% overall shrinkage in September of 2021 to under 10% in April of 2022. So extremely successful and much appreciated all the way to our CAO, this tremendous improvement on the infusion services.
I think we're going to have to adopt this technology for us to be able to adapt appropriately into the future. It's just the pressures are too high from a cost perspective, from a revenue perspective, from a payer standpoint. The pressures are way too high for us to not, evaluate and leverage and continue to use these technologies to drive more efficiency with what we do on a day-to-day basis.
The partnership with LeanTaaS has been excellent. Like I mentioned at the beginning, I've worked in this capacity for 2 years, and we have regular meetings with the LeanTaaS team to troubleshoot any system setup issues or questions regarding user access, training. It's been a really good partnership. They are timely with their responses. And the other feature I do want to bring up, I haven't mentioned yet on the IQ system, is they have a help desk, a question on the help desk where if I'm an office scheduler and I have a question that I need to be answered right away, I can type my question right into that helpline, and the response and communication back from the IT team with LeanTaaS has been great. They've been a great partner.
Science needs to be the driving force around capacity management. It is no longer something that you can do with a pencil and a pad of legal paper. We need to recognize that it has advanced past that and will never go back. Knowing where we were, and then with the real-time understanding, the next obvious step is to see, well, let's not guess anymore. Let's see if we can use data to inform our anticipatory decisions. And staff are tired, patients are sicker, care is more complex, and the care has arrived before we can put in large capital investments in things like buildings. So these are the levers that we really have to pull quickly. Let's bring in some advanced tools. We've gone through all that. We understand each other to a certain extent. Let's see what new levers are out there using forward-looking information to try to mitigate those bottlenecks that we can mitigate, understanding we'll never get to zero.
Weeks of nurse poll at Duke Cancer Center. Staffing remained stable and infusion wait time decreased by 44%. And there was a 27% in infusion wait time despite serious staffing fluctuations. So remember, the system, if you have serious staff issues in terms of people being out, it does reduce the effectiveness, but it's still the least worst option. So it's still a whole lot better than it would have been under the other allocation methods. So accounting for that, about a 27% decrease in infusion wait time over the time that's implemented. One thing I didn't mention, by the way, is that under a poll system, the way that patients come in and the way that pharmacy fills orders starts to get in much more close alignment. So the very first thing that we see when we implement poll is drug wait time drops, and it typically drops by 15% or so almost immediately. And we see that here. So drug wait times have dropped 15 minutes and nurses are getting out early. That's from Novant. And so again, I encourage you to at least think about it.
So we saw that that our average time frame for proactivity released is hovering about 19 days. So this is almost 3 weeks in advance of the block being auto-released that our offices are proactively releasing. And this helps us to backfill that open time that may otherwise go unfilled. Second, we were seeing that our release fill rate was hovering about 49%. So this is a data piece that we keep track of, understanding if how much of the time that's released is actually picked back up and used. So we're seeing almost 50% of the time that's released is getting used. And then lastly, our OR utilization for our pilot sites have been hovering at 80% utilization. One of the benefits that really helped us in making this project very successful is how LeanTaaS helped cater to us to fine-tune this tool for us. LeanTaaS did an incredible job helping us understand the tool, what the data meant, and basically helping us come up with a communication plan to how do we communicate this out to our peri-op leaders, our surgeons, and our clinics that are affiliated with us.